Good afternoon and welcome to the Cardiovascular Kidney Metabolic Syndrome session. Thank you to those who've stayed for 4 p.m. I know it's been a long but incredibly interesting day. I'm Associate Professor Claire Arnott from the George Institute for Global Health. I'd like to start by acknowledging the traditional owners of Naarm, the people of the Kulin Nations on which we gather here for this meeting. I'd like to pay my respects to elders past, present and emerging, and extend that respect to any Aboriginal or Torres Strait Islander people here with us today. CKM syndrome, which encompasses cardiovascular disease, kidney disease, diabetes and obesity, is one of the leading, if not the leading cause of death and disability globally. And we know that it's very tightly connected with the social determinants of health. It's worsening. We have a global pandemic of CKM, and as such, the American Heart Association recently released a presidential advisory statement and a call to action for us as a global community to take CKM seriously and to address CKM. Today, in this session, we're going to do that with a real focus in the Asia-Pacific area. We're going to look at equity and disparities in outcomes in our region. So I'll do that today with my amazing co-chair, Professor Sophia Zungas, who is the head of School of Public Health and Preventative Medicine at Monash. And we also have 4 incredible speakers here today across our Asia-Pacific region. Followed by our 4 talks, we will have a panel discussion, and I want to emphasise that we will absolutely be talking about disparities and issues and problems, but we also want this to be a positive session, and we're going to be talking about a way forward, and that's a collective way forward. So how can we come up with meaningful solutions and a path to improving outcomes? So with that said, I would like to introduce our first speaker. It's a privilege to introduce the Honourable Mr. Lalabalavu, who is the Health and Medical Sciences Minister for the Fijian Government. And he'll be talking to us about CKM in a Fijian context.
Bolubinaka, and again, thank you very much for allowing me to share Fiji's experience with regards to CKD and NCDs in total. Just before I start, I thought to acknowledge the traditional custodians of the land that we're in the tradition, in the Fijian vernacular. And I pono viti o tō rangonongo mo ndole kina na wāpini pinaka no vukuni wekinta waki mai tā kana matakalele ngoe no vukuni isile isara laka wili mai na minda mai tiko and I'm boss in World Health Summit in Melbourne, Naksawa Libu. The session moderator, distinguished fellow speakers, members of the forum. The prevalence of non-communicable disease poses a formidable challenge to the healthcare system in Fiji and the broader Pacific region, with about more than 5,000 deaths yearly, mainly before retirement. NCDs strain healthcare and hinder Fiji's development. Some statistics, economic analysis show NCDs account for 40% of health spending, while 5% of GDP could be lost annually due to reduced productivity caused by illnesses, early mortality. Among the health concerns, cardiovascular and kidney disease stand out as significant threats to the well-being of our communities. Talking about cardiovascular and kidney metabolic syndrome, the intricate interplay between obesity, type 2 diabetes, cardiovascular disease, and chronic kidney disease constitute a complex of health crisis as recognized by the cardiovascular disease metabolic syndrome by the American Heart Foundation. I won't touch in particular on the science of it, but addressing the prevention, management, and treatment is paramount to promoting better patient health outcomes. The overview of the current burden of cardiovascular disease and kidney disease in Fiji. Cardiovascular disease remains the leading cause of death in Fiji, representing a substantial burden on our healthcare system in 2017. It was estimated that cardiovascular disease caused twice as many deaths as those by diabetes, which is in line with global trends. Kidney disease often stems from diabetes and hypertension, echoing the same lifestyle and health management issues that fuel cardiovascular problems. The increase in kidney disease prevalence is alarming, with a rising number of individuals with chronic kidney diseases that require dialysis treatment, significantly straining our already limited and scarce healthcare resources. In 2017, the Global Disease Burden Collaboration estimated the prevalence of chronic kidney disease in Fiji could be as high as 13%, which is significantly higher than the global average of 9.1%. In addition, the annual incidence of stage 5 chronic kidney disease is estimated to be between 753 to 938 per million population, which is 5 times the incidence reported in Australia in 2013. So several factors have been contributing to this alarming situation of cardiovascular disease and kidney disease burdens, including the high rates of hypertension, obesity, and diabetes, and exacerbated by lifestyle choices and economic challenges, so to speak. One of the greatest challenges and intermediate risk factors of NCDs like cardiovascular disease and kidney disease is obesity, as you all know. Fiji, like many Pacific Island nations, faces a critical challenge with obesity. Often a traditional diet once rich in fresh fruits, vegetables, and seafood have been overshadowed by modern diet, high in processed foods, sugars, and unhealthy diets, and healthy fats. This shift, coupled with the decrease in physical activity, has resulted in one of the highest rates of obesity in the world. Global Nutrition Report of 2018 estimated that Fiji's obesity rate at 38.4% for women was higher than the regional average of 31.7%, while the rate of 28.4% for men was lower than the regional average of 30.4%. So the data clearly shows the obesity issue we're having with not only within Fiji, but in the Pacific as well. So obesity is not merely a matter of individual health, but a social concern that increases the risk of numerous other diseases, including type 2 diabetes, again, heart disease, and certain forms of cancer. And the significant impacts of quality of life, reducing both life expectancy and the enjoyment of life, most precious moments decrease in the quality of life afforded to individuals. The Fijian population faces unique risks due to dietary preferences for high in saturated fats and sugars, and shift away from traditional plant-based diets. Moreover, the accessibility of healthcare and early detection programs vary significantly across our islands, impacting the effectiveness of preventative measures. And in addition, limited access to healthcare services for the prevention, diagnosis, and management of NCDs like cardiovascular disease and kidney disease, particularly in rural and remote areas, further complicates the situation further. Strengthening healthcare infrastructure, including primary care services and specialized cardiac care and kidney care facilities for primary, secondary, and tertiary prevention is essential for addressing cardiovascular disease and kidney disease effectively. Now, public health interventions such as health education and promotion, screening and early detection, public policy interventions, research surveillance, and development while ensuring that we are managing NCDs such as cardiovascular disease and kidney disease is according to be best practice in low-resource countries such as mostly in the Pacific are necessary. In recent years, initiatives such as the introduction of tobacco legislations, sin or sugar tax, efforts to reduce the salt intake and excessive carbohydrates, and community-based health programs aim to curb the rising tide of cardiovascular disease, diabetes, and kidneys. Now, overall, addressing NCDs or CVD and kidney disease in Fiji requires a multifaceted, cross-sectorial approach that addresses both the underlying risk factors and the healthcare system capacity to prevent, detect, and manage the conditions effectively. While the national statistics that I have stated are alarming, we are determined to tackle this crisis by implementing a comprehensive public health approach that prioritizes prevention, reduce risk factors across the population, improve disease management, and provide sufficient support system to improve health and economic outcomes for all Fijians. And in addressing the health challenges effectively in Fiji, we must foster strong collaborations in international health bodies with international health bodies and invest in sustainable healthcare education infrastructure. Moreover, it is empowering communities through education that will enable individuals to make informed health decisions, potentially reducing the prevalence of disease linked to lifestyle choices, investing in research specific to our demographic and environmental context. This is important, that will also yield intervention more suited to our unique needs. For Fiji, the new National Wellness Strategic Plan of 2023 to 2030 is Fiji's dynamic solution to realizing NCD prevention and control targets. We understand that socio-economic changes, development, and urbanization in Fiji have boosted healthcare access and living standards, yet also to unhealthy behaviors and a rise in non-communicable disease. And our Wellness Strategic Plan for 2023 to 2030 builds upon learning from the past efforts to enhance wellness in Fiji. In 20 years, our wellness vision for Fiji is a society where every individual thrives in body, mind, and spirit. We envision vibrant cities, protected natural environments, and accessible, culturally rich communities. Our focus is on promoting health through safe environments, healthy food options, and quality healthcare services, while fostering resilience and strong social connection to navigate social changes. Just to conclude, while the road ahead, not only for Fiji and the Pacific, is challenging, it is also filled with opportunities for significant improvement. By uniting our efforts and focusing on strategic opportunities and engagement, we can yet prevent, control, and reduce the burden of cardiovascular and kidney diseases in Fiji. Again, that is my contribution for the time being, and we'll entertain any question at the time comes. No.
Minister, thank you for an incredibly impactful talk. The statistics are sobering, but something that I think really resonated and stuck with me was what you said about the need for a cross-sectorial approach that is region-specific, that's Fijian-specific, and I think that's something we'll probably pick up a lot more on in our panel discussion. But it's now my privilege to introduce Associate Professor Lim, who's Deputy Head of Visibility Information and Communication at the Faculty of Medicine at the University of Malaya. And she'll be speaking to us about the burden of CKM in Asia, gaps in evidence and barriers to implementation of guideline-directed therapy.
Thank you, Claire, for the kind introduction, and thank you very much to the World Health Summit organized by Monash University under the leadership of Professor Supezongas for the kind invitation. So my presentation will be more towards the CKM management in the Southeast Asian region, focusing in Malaysia, that would be my country. So if any of you are not sure where is Malaysia, Malaysia sits in the ASEAN, and we have about close to 80% of the urban populations. We belong to the upper middle income country with a GDP per capita of close to 14,000 of US dollar, and our Gini coefficient is about 0.4. Life expectancy for men is 73 years old compared to women who live longer at 77 years old. And we're also facing an increasing number of aging populations, estimated by just about 4 years ago, about 8% of our population age more than 65 years old. And Malaysia is a multi-ethnic country. 70% actually having Malay ethnicity, and Chinese and Malaysian Chinese is about 23%, and followed by Indians, fewer than 10%. And if we look at the global burden of disease data, in Malaysia, the cardiovascular kidney and metabolic syndrome constitute the top 5 causes of all-cause death. If we're looking at the cardiovascular disease, it just maintains status quo from 1990 until 30 years later, about 20 years later until 2019. And about diabetes and chronic kidney disease is about the 3rd and the 4th top causes of all-cause death in Malaysia. And why is that so? Diabetes as well as obesity are the 2 main health conditions impacting the Malaysian population. We actually have the highest prevalence of diabetes in the ASEAN region, and close to 4 million of them if you look at the population-based survey published in 2019. And every 1 in 5 adults aged 18 years and above in Malaysia would have been living with diabetes. And alarmingly, the prevalence of undiagnosed diabetes is high. Half of them were undiagnosed. And therefore, they would have presented to a healthcare facility already developed diabetes-related complications will require additional care and additional healthcare cost. Nevertheless, we are also facing with the obesity wave. If you look at the estimated prevalence of obesity by 2025, looking at Malaysia, about 1 in 4 people, adults aged 18 years and above, would have lived with obesity issue. Vietnam and Singapore has the lowest prevalence of obesity in the ASEAN region. Just putting aside all this epidemiological data, what will be the current status of the cardiovascular kidney and metabolic syndrome care in Malaysia in the publicly funded healthcare facilities? What you can see from here, the target type 2D data were just published earlier this year, in which I'm the lead investigator. We're looking at about 6,000 patients with type 2 diabetes, mainly in the urban capital, in the Kuala Lumpur region. We have a mix of the Ministry of Health and Ministry of Higher Education of healthcare facilities. The mean age is about 60 years old, with a long disease duration, about 15 years. But if we were to compare the risk factor control and the risk factor attainment versus the National Diabetes Registry, close to 300,000 of them, mainly will be primary care population, publicly funded clinics. The risk factor attainment didn't differ significantly. The mean A1C is about 8 to 8.2%, whether you are being treated in the primary care facilities or in the tertiary hospital. And our people is actually having either overweight or obesity with a mean BMI of close to 30 kilograms per meter square. But if we look specifically into visceral adiposity, and we're actually using Asian cutoff, women will have diagnosed to have visceral adiposity when it's more than 80 centimeter, and men will be 90 centimeter. And looking at that, women are actually facing the visceral adiposity issue higher than men, with a mean waist circumference of 90 to 100 centimeter. Then what about lipid lowering? Are we really treating our patient well? Looking at the mean LDL cholesterol, the level was actually 2.5 in the hospital-based patients versus 3 millimole per liter of the primary care populations. And again, when we actually analyze the target type 2D data, mainly will be hospital-based patients using the ESA 2019 criteria, we actually came with a shock because close to 100% of the patients in that cohort is actually at least high and very high risk. Then what about the prevalence of comorbidities? In the hospital-based patients, 1 in 3 would have suffered from atherosclerotic cardiovascular disease as compared to a lower proportion among those with, in the primary care setting, just 5%. And about 4% of patients of the treated in the hospitals would have complained of the previous history of heart failure hospitalizations. But kidney disease seems to impact Malaysians with type 2 diabetes more. Looking at the proportion of patients who complained of albuminuria, about 2/3 of them, and what about those with the eGFR of lower than 60 mils per minute, again, is about 1/3. What about the use of some of the guideline-directed medical therapy? If we were to compare the hospital-based patients, which is the green column, versus the gray column with the primary care populations, you will realize that primary care population, about half of them were treated with sulfonylurea. They have a lower proportion of the insulin use, and they also have a lower proportion of the use of RAS inhibitor and statin, ranging about 60 to 70%. Just keep this in mind, because we're to show to you what will be the trends of the rates of death due to any cause, as reported here among the 16 high-income countries, in which Australia is represented by the red line. It's actually declining from 1995 until 2015, and the rates is just about 150 to 250 per 10,000 patient year. I'm going to show you what will be the rates of all-cause death among people with type 2 diabetes in Malaysia. It's actually plateau, and a certain patient group we see an increasing rates of all-cause death. On the left-hand panel will be type 2 diabetes patients without any prevalent history of cardiovascular death, and the rates of death due to any cause is 2 times higher as what you have seen in the previous slide, 250 to 400 per 10,000 patient year. And we look at the line chart, the blue color, for those with a prevalent history of cardiovascular death is actually increasing in trend from 2012 until 2019, standing until 600 patients would have died in 1 year among 10,000 of them. This is 3 times higher than what I presented just now as what has been experienced in Australia and other high-income countries. And is it only diabetes population? Sorry, okay. If I were to show you what we see from the National Cardiovascular Disease Database, 60% of patients who actually presented to our cardiologist for any of the percutaneous coronary intervention had 3 or more risk factors. And what are these risk factors? It's all relevant to diabetes and obesity. It's either diabetes, having obesity, having hypertension, dyslipidemia, or smoking. So this shows how substantial in this diabetes and relevant comorbidities are affecting the general Malaysian population. Fiji is also facing a significant kidney disease burden. Malaysia is not being spared anyway. We are actually at the brink of a kidney disease crisis. The Social Security insurance expenses needed to cover for dialysis has increased by close to 300 times in about 20 years. And currently, it's about 50,000 Malaysians are living with end-stage kidney disease. And the Ministry of Health had projected that about 2 times more, meaning close to 110,000 Malaysians, could be on dialysis just about 16 years later. And we realized that newly diagnosed patients suffering from dialysis would be at least 10,000 people per year. And more than half of them, they have diabetes. So we need to ask ourselves, from the Malaysian perspective, we still see residual cardiovascular, kidney metabolic, and death risk, despite close to 60 to even 70% coverage of RAS inhibitors and statin. But is that so? Are we doing enough to trying to salvage the health outcomes to provide better health to our patients? If you look at the WHO Global Diabetes Compact, we are trying to come up with a national level metrics to improve health outcomes of people with diabetes. And what we have proposed is actually the 80-80-80-60. This is a magic number, just like the HIV. And the ultimate aim is to halt rise in diabetes and obesity. And what's the first 80 meaning? It's actually the proportion of population with diabetes who have been diagnosed it should be 80%, but in Malaysia, I presented to you just now, just half of them have been diagnosed. What about glycemic control? The population level, the proportion of populations with diabetes managed to attain an A1C of less than 8%, it should be 80%. And the proportion of population with diabetes managed to attain a blood pressure of lower than 140/90 millimeter mercury, it should be 80% or beyond. Then what about the use of statin and lipid lowering? It should be at about 60% or beyond. And ultimately, we hope that if the Ministry of Health of every country would have reported to the World Health Organization on this national level metrics, we look into improvement of the long-term health outcomes. We want to reduce the all-cause mortality, end-stage kidney disease, the lower extremity amputation, and even we also want to look into the preventive approach, minimize the incidence of diabetes. Showing you will be the comparison of the regional performance of the WHO Global Diabetes Compact. Summarized for you here, again, the magic number would be 80, 80, 80, and 60%. If we just show across the Asian Pacific region, if you look at Malaysia on the middle panel, which represents the upper middle income country, we just managed to meet 1 out of the 4 national level metrics. If we were to compare to Indonesia, Philippines, and even Thailand, who belong to the low and middle income country in the ASEAN region, none of them will have achieved these 4 levels, 4 types of national level metrics. What about high income region, for example, Hong Kong and Taiwan? So Hong Kong performed better. They only met 50% of the 80, 80, 80, 60. And Taiwan, again, it seems that the statin and lipid-lowering use would be the best indicator they managed to achieve. So are we doing enough? Are we just looking into risk factor attainment as what has been recommended by the WHO Global Diabetes Compact? Is there anything else that could help to improve the CKM syndrome? Looking at that, of course, we know there have been robust cardiovascular kidney protective benefits as has been asserted by these SGLT2 inhibitors and GLP-1 receptor agonists. We are not spared, actually, in the ASEAN region. If you look at the global level, looking into the Hong Kong Asian Pacific region, this is the study until 2019. Despite the announcement of MPRI outcome since 2015, the proportion of use of SGLT2 has increased over time from 2015 and it's 2019, but just stand at merely 5% of the patients with type 2 diabetes. Then what about in the States? This is the entire group who are actually at the higher risk of recurrent cardiovascular risk. Those with type 2 with concomitant atherosclerotic cardiovascular disease, you may realize the use of sulfonylurea, the orange-colored line, has dropped, and the utilization of DPP-4 inhibitors has reduced, but the increment of the use of newer generation of guideline-directed medical therapy, mainly it will be GLP-1 receptor agonists and SGLT2 inhibitors, just stand below 20%. So what are the challenges to the implementation of guideline-directed medical therapy, not only at the global level, but also in the Asian Pacific region? It lies beyond the 3 main factors: health system, healthcare providers, as well as patients. We face problems with financing model. We also face problems in having adequate and appropriate training, distribution, and retention of health workforce. And again, it's not one size fits all, because we need to develop, we need to validate, we need to implement these specific context-specific protocols which culturally and socially acceptable across the spectrum of CKM syndrome: how to screen, when to diagnose, when to refer, and how to treat. What about in terms of the health workforce? We see commonalities. We tend to have therapeutic inertia. Why is that so? Is it because of knowledge or communication gaps? Is it because uncertainty about trial generalizability? Or there has been biased decision-making? We tend to have discrimination while doing our clinic consults because we feel that elderly population may not fare better, or there's a certain socioeconomic status patients may have benefited from certain therapies. And this goes back to, is there any way for us to help to curb this problem? And several responses have been received. There's a lack of interdisciplinary care to support primary until the tertiary care level. There's also insufficient opportunities for treatment re-evaluation. What about patients? Patients may have suboptimal health literacy. Just sharing the health literacy level in Malaysia is just about 20%. And there's been lack of insurance coverage of affordability because, again, this back to the healthcare financing. We have one session here in the World Health Summit talking about how to remodel and restructure the healthcare financing. Obesity treatment is not covered by insurance, and not all patients with diabetes in general, they tend to be denied of having insurance coverage. And therefore, you may see there's been attrition rate. Patients tend to have non-adherence to their current treatment. And just now I was saying that aging population is again, we are having this issue in Malaysia. The frailty index may have increased. They would have developed complex morbidities, will make things to be harder. There have been competing priorities in terms of the implementation of GDMT. So what are the 5 key gaps in optimizing cardiovascular, kidney, and metabolic care in low and middle income countries? If we look at these gaps, and there would be significant opportunities. The first gap would be there's been a lack of electronic medical record system use. We do not have national information standards or code sets. We have limited technical expertise and infrastructure to support that. And therefore, you may realize there has been limited interoperability and there's been difficulty in having data sharing. There's a lot of concerns about data privacy and security. And of course, again, the entire organization, or even people, they have resistance to change behavior. And because of the lack of the EMR use, you may realize we have a lack of longitudinal cohort data for the estimation or calculation of event rates. And we also have a limited cost information to help policymakers to plan for their healthcare policy because we won't be able to produce sufficient data for the local economic evaluations. Again, we do have policies to curb diabetes, obesity, to curb the CKM syndrome, but there has been limited policy implementation, evaluation from a multi-level perspective. And last but not least, there will be a lack of patient and public involvement in the policy and research design. Showing here would be an example of this problem that recently we have actually, the health ministry has launched Kurang Manis, which is the Malay terminology for less sugar campaign. Putrajaya is actually one of the capital city in Malaysia, and it actually struggles. This is a good campaign, struggles to sway the taste buds of the Malaysian population. If you're looking at the public perspective, what do they mean by that? You say, even though the hawkers are willing to accommodate requests for less sugar, there has been minimal demand, and they actually affect their business. The other thing, one of the public feedback would be, what if we actually provide financial incentive? Just make the people pay extra if they were to request for extra sugar. So if we were to have public feedback or patient feedback while designing policy, this might have helped this less sugar campaign to be even more successful. So looking at that, what would be the potential solution and implementation roadmap? Healthcare system is a learning system. We need data and knowledge in order to generate, to influence practice. And a good practice will help us to generate even more data and knowledge. But we can't work alone, because we need the governance support. We actually need the researchers, the academicians, we need people on the ground, we even need the public and patients to tell us what to do, what are the gaps, and how to do it to have the maximal impact. And this is a very good algorithm for me, trying to convince people how are we going to tackle therapeutic inertia. It's the A, B, C, D, E, F, G. A is we need to be the advocates to reduce therapeutic inertia, be a voice. We need to collaborate, not working in silo. We have to deliver interdisciplinary care, educate the reimbursement authorities, because some of the conditions we do need to influence policy and practice. Again, patients shouldn't be left alone. We have to facilitate patient empowerment, and we also need to gauge what would be the individual physician performance that needs to be audit and benchmarking a system to be in place. These will be the last few slides I'm showing as an example. In Malaysia, we realized that non-communicable diseases constitute a major problem in our healthcare system. It actually takes up close to 20% of the total healthcare expenditure in Malaysia, and about half of them has been spent on treating diabetes alone, and the remaining for the second in line will actually be cardiovascular disease, which again, I've shown you, is a major contributor. The major culprit is still diabetes. And the Ministry of Health, together with the Ministry of Higher Education, will come up with the NCD targets for Malaysia in order to meet the 25 by 25 WHO, the United Nations Sustainable Developmental Goal. There's few examples in order to reduce premature mortality by 25%. We have the enhanced primary health care strengthening surveillance. We also have the smoking products bill, which just recently passed, also looking into reduction of salt to minimize hypertension. We have quite successful salt reduction strategy. What about physical activity? It's a tropical country, it's unlike Australia. We are blessed with very good weather. We have the National Action Plan for Active Living, focusing on behavioral modification, and again, also looking into industrial collaboration. We have concomitant alcohol prevention and harmful use national action plan. And ultimately, if we look at the prevalence of diabetes and obesity, we propose that we need to halt the rise, trying to meet really as a 15% reduction of the prevalence of diabetes and obesity. And therefore, we have really strengthened the National Action Plan for Nutrition, because education starts from school and education starts from workplace. There will be peer-to-peer pressure. We're also trying to meet the 80% proportion of diagnosed diabetes population as recommended by the WHO Global Diabetes Compact. So through the COSPN initiative, we're trying to escalate screening for diabetes. With that, thank you for your kind attention. Okay.
Thank you, Professor Lee. And I think it's quite compelling that you indicated the barriers to, meeting those targets and new indicators. So lots more work to be done. And it's interesting because our next speaker is going to talk about their experience in terms of research. And you made the point that we need more research and representativeness of participants from our region in that research, so the generalisability is not an issue. So thank you. Our next speaker is Professor Steve Nichols, and he's my very good friend. He's the inaugural director of the Victorian Heart Hospital and the Victorian Heart Institute. He's a world recognised, renowned cardiologist. He's been the chair of many cardiovascular outcome trials, and he's going to share his experience of setting up a research and a research agenda on cardiovascular kidney metabolic disease in the Asia Pacific. Thanks, Steve.
Thank you, Sophia. Good afternoon, and thank you for the invitation. This slide summarises my disclosures. Cardiovascular disease remains the leading cause of death and morbidity worldwide. And while we've seen profound advances in our approaches to preventing and treating cardiovascular disease, it's fair to say that the majority of those advances have occurred in higher income countries where we've seen a spread of cardiovascular disease across lower and middle income countries, which now really account for more than 75% of the global disease burden. So we're left with a desperate need for workable solutions that will address healthcare disparities in these countries. And we also need to acknowledge that the cardiovascular solutions for many countries have not been considered at all. The Asia Pacific region is the most populated region in the world. It's responsible, it houses more than 60% of the world's population. Annually, nearly 10 million people die due to a cardiovascular cause, which attributes to nearly 50% of all non-communicable deaths in the region. The rise in obesity and the metabolic risk factors, plus the environmental pressures, continue to play a pivotal role in driving cardiovascular disease. So on one hand, we need effective public health measures. On the other hand, we need implementation of proven cost-effective therapies. And we do all of this on the background of the factors that we talk about a lot at a meeting like this, which are going to play just as much across all of the countries of this region: the social determinants of health, the environmental factors, which we see pollution be a significant factor in many of the countries in this region, and on a background that it's not just about the innovative therapies that might be developed by large pharmaceutical companies, but it's thinking about how that will work on a background of traditional and regional therapies that may be important in particular kind of jurisdictions. Now, the sobering reality is that while the large burden of cardiovascular disease exists within the Asia-Pacific region, these individuals are poorly represented in large clinical trials. This is an analysis that our group conducted of Tier 1 papers in the cardiometabolic trials over a decade from 2011 to 2020. And you can see that while 60% of cardiometabolic disease burden is in the Asia-Pacific region, less than 10% of individuals that are enrolled in those trials actually come from that region, and that correlates pretty closely with authorship and representation in terms of lead investigators in those studies. Not surprisingly, as we've seen, an increase in representation by lead authors in those studies, we have seen a small increase in Asia-Pacific representation. And if this is a heat map of where you see those authors come from, and so bar one or two countries in the region, most of the countries in the Asia-Pacific region are poorly represented in terms of leadership of clinical trials, in terms of authorship of clinical trials, and so that's going to have a trickle-down effect that we're not going to focus and prioritise on enrolling patients from these regions in our clinical trials. So we have a paucity of local evidence. We know that there's increasing regulatory requirements to have local efficacy and safety data for approval in some countries. We know that clinicians will inevitably demonstrate considerable inertia and failure to adopt new therapies. Some of that is just the typical inertia that we see, but some of it will be an attribution, well, the patients I see weren't included in the clinical trial that you conducted. Now, we are seeing that some countries are having regulatory requirements that may be satisfied by including local patients in small and short-term studies, but that doesn't solve the lack of omission of local patients from large cardiovascular outcome trials. There are perceived regional clinical differences. We know that there is a high prevalence of hypertension in the Asia-Pacific region. We know that there's a high prevalence of stroke, and that there may be concerns that there may be a greater perception of stroke as a clinical concern compared to coronary disease. That may limit interpretation of some of the clinical trials that we conduct. We know that there are differences in pharmacodynamic effects in some parts of the region. For example, we know that there's greater lipid lowering with lower statin doses in East Asia. That may limit interpretation of large-scale clinical trials, and that ultimately raises concerns on how best to implement where there's no local experience. There's tremendous diversity across the Asia-Pacific region. Our individual countries vary in terms of the individual cardiovascular disease prevalence. They markedly vary in terms of cardiovascular mortality. And as you can see, there's a range of factors. Some of them are individual, some of them are socioeconomic, some of them are environmental, and some of them are fundamentally the healthcare systems that we have in place that are likely to contribute to that variation. Ultimately, those differences may influence the risk of clinical events in different countries, the tolerability of medical therapies, the background standard of care, which we might see in clinical trials and at least try to consider in terms of implementation, and finally our ability to access clinical trial networks. And ultimately that presents a challenge for implementation of the findings. It may limit the translation of findings to broader populations in each country. It may limit the demonstration of potential differences in efficacy between countries, and the poor regional representation really limits the power to demonstrate any statistical heterogeneity, even if it were to exist. We know that there's limitations in terms of our ability to deliver clinical trials in every country across the region. There are challenges to be able to do that. It includes our complex and varying healthcare systems, our dispersed populations in many countries, many individuals living in rural settings, a long way away from large medical centres, which are typically required for conducting large-scale clinical trials. The presence of multiple dialects and languages may influence the ability to simply roll out clinical trials in a given country. And the varying use of databases and digital technologies produce a number of other challenges. Now, there are a number of local solutions that have been delivered by both local academic and contract research organisations to overcome many of those challenges, and we've had a number of success stories in this space. We see the conduct of a very large salt substitution study in China not only provide really important data from a preventive perspective in Chinese communities, but has implications that advance far beyond its shores. We see studies conducted in Korea where we actually try to take advantage of that notion that individuals in East Asia may have more potent lipid lowering and more tolerability with lower doses of statins, looking to look at the combination of using lower intensity statins and ezetimibe compared to higher intensity statin alone, and actually that providing important evidence to satisfy and reassure clinicians that that can be an effective clinical therapy moving forward. We established an academic collaboration focused on cardiometabolic disease across the region with good but not perfect representation, and this continues to grow in terms of its membership. It allows for us to do a number of things, one of which is to conduct clinical trials across the region. One study that we're kind of performing at the moment, Goal Asia, involves enrolling 2,000 patients in 8 countries across the region following a myocardial infarction, randomising those patients to standard of care or assisted goal counselling to see if we can enhance the ability to bring more patients to their lipid targets over the next 6 to 12 months. An important study in terms of implementation, but equally an important study to try and understand what are the pros and cons of being able to try and conduct a study across a diverse region with the number of the challenges as I've highlighted. We have a significant need for capacity building. We need more academic investigators. We need more research infrastructure so that we can have effective operational trial delivery that's focused in the regions in a way that can be effective. We need to take trials to people so they can be delivered within their healthcare services. And we need a greater investment from government, industry and academia to kind of grow this capacity. There are a number of opportunities that we need to kind of see how we take advantage of. The Asia-Pacific region is highly populated. It is also a cradle for great innovation. This is just one example where we've seen the number of pharmacological therapies that are coming for regulatory approval increasing substantially coming from countries within the region. So the innovation is here and will need to be evaluated. We're seeing the connectivity to our patients and our communities advance. We're seeing an increase in the proportion of mobile phones that employ smartphone technology increasing substantially. By the year 2030, it is predicted that nearly 94% of mobile phones in the region will be smartphones. That gives us a great ability to be able to connect to our patients. We're seeing a substantial rise in wearable medical devices. In fact, predictions are that the wearable medical device market will more than double over the next 5 years. Gives us, again, incredible opportunities how we connect with our patients within our clinical trials. We need to seize the opportunities that artificial intelligence allows us in terms of all steps of the clinical trial process, how we can more seamlessly design our studies, enrol our patients, remain connected with our patients, evaluate our patients, and hopefully to be able to do that with our patients embedded within their healthcare systems and close to home in the real world where the clinical trial results should be more applicable. And then finally, we need to think about the patient at the centre of all of this, and the fact that patients are demonstrating a greater voice, they're rallying together, and it's an opportunity for us to be able to think, how do we bring patients and the community front and centre so that they play an active role in designing clinical trials that effectively work for them, that provide solutions that will improve their health outcomes and ultimately will provide a much better platform for implementation of proven therapeutic strategies into the real world. So the Asia-Pacific region is a large region. It's got a large cardiometabolic burden. There are a lot of challenges to being able to perform clinical trials in this region, but there are a lot of opportunities and solutions which I've highlighted. So trials can establish the utility of innovative and repurposed agents in a high cardiovascular disease burden region. They provide the framework for implementation within health services, tailored to cultural and contextual nuances that are specific to the region. We need regional solutions to transform the large burden of cardiovascular disease that we see today. It's time for cardiovascular clinical trials to meet this challenge. I thank you for your attention.
So I think, thank you, Steve, for that compelling argument, and segues quite nicely into our final speaker, Professor Alta Schut. Welcome, Alta. Alta is the Professor and Principal Theme Lead for Cardiac, Vascular and Metabolic Medicine, School of Population Health at University of New South Wales in Sydney, Australia. She's also a Professorial Fellow at the George Institute for Global Health in Sydney. And Alta will be presenting on how we may consider access to therapeutics and access to care and how we improve that with that equity lens. Thank you, Alta.
Good afternoon, everyone. Thank you very much for the invitation to this meeting, Sophia, Claire. It's a very interesting session. It's actually a very important session as well. And I've been given a very difficult task to speak on the development and delivery of affordable medicines to the regions that need it most. I've tried to disentangle the title a bit and focus on specific sections and start off with the regions that need it. We've had some really good speakers already focusing on the regions that need it, and I want to highlight some of that a bit, bearing with me coming from a blood pressure, hypertension background, so I use it sometimes as a model, but I will speak on the overall challenge that we face with NCDs, including cardiac, metabolic, and kidney disease. And so, very well known, the global burden of disease study have shown that when you compare several risk factors over time and their contribution to death, high blood pressure, systolic blood pressure remains the leading cause of death in the world, resulting in about 11 million deaths each year. That's 20% of all deaths, and that's about 30,000 deaths per day. People with high blood pressure you can almost say always, have other conditions as well, whether it's dyslipidemia, it results in kidney disease later on. So it is indeed a syndrome that we are dealing with, and you can't only look at one single risk factor at a time. But if we look at the regional distribution and in terms of the prevalence here, you will see that for hypertension, and I'll show in a bit also for diabetes and other conditions, that it's often here where you can clearly see the inequities in terms of prevalence being more so in low and middle income regions. If you look also at the change in the prevalence of high blood pressure, hypertension over the past 30 years, the green areas on the map are those that have seen an improvement in prevalence, whereas the orange regions have seen an increase in the prevalence over time. This is for women, and in the next slide, this is for men. And you can see, again, low and middle income regions, that is where you actually see an increase in prevalence of hypertension. But we can look at maps and we can look at data all we want, but in the end, the data doesn't always show the real life settings that we see. And it's often this immense challenge in these settings where we have very low ratios of physicians or doctors to patients or nurses to patients, and have to see the whole challenge and of the healthcare system, which adds to the challenges we have in terms of getting the right medicines to people who need it most. If we look at hypertension, for example, again, 1.4 billion people have been estimated to have hypertension in the year 2010. We don't have much more recent data, but it's likely to have simply increased. But over 1 billion of those reside in low and middle income countries. So I think, again, it's much more important to look at actual data in terms of absolute numbers. And you can see here, if you look at, for example, on the right-hand side, the red bars, that's women in low and middle income countries compared to in high income countries. And if you look at the age group, let's say 40 to 49, you can see that 100 million women in low and middle income countries have hypertension compared to less than 20 million in high income countries. And so it's these absolute numbers. Millions of people in those regions with already challenged healthcare systems is where we face this problem. And that is also what we have found here when you look at the deaths due to cardiovascular disease. In high-income countries, on the left side of the column, the deaths due to cardiovascular disease is about 133 people per 100,000 deaths, whereas that's double the number in upper middle income countries and even more than double in lower middle income and low income countries. And that is again due to the whole healthcare system. This is for diabetes prevalence, as I've mentioned before. So this is, you can see that although there are obviously high income countries that are also suffering from this whole rise in diabetes, it's often in low and middle income countries where we also see the problem that it's rising along with obesity, as some of the previous colleagues have mentioned. But I do want to highlight again, and I think often we can learn a lot from the infectious disease challenges we will have faced. COVID is one good example, is that access to care. And if you can look at the data from 30 June 2021, the share of people who received one dose of COVID-19 vaccines, and 6 months later, it has changed substantially. And you'll see many low and middle income countries have improved substantially, but others didn't. So it's often also related to that political will in terms of making sure that there is that access to, in this case, COVID vaccines. Steve also mentioned in his presentation the mobile phone subscriptions, and you can see that there is, depending on the willingness and the interest and the importance as experienced from local levels, if you look at mobile cellular subscriptions in the year 2000, and just 17 years later, it has changed and transformed tremendously, and that is a huge opportunity to work through other means to get to people how they need it, and we have to start thinking innovatively. We can't just do things the way they have been done for so many years if we really want to make an impact and change. Let's look a little bit at affordable medicines with an emphasis on affordable. In this paper from the Peers study, which included data from 21 low to high income countries, looking at the availability and affordability of blood pressure lowering medicines, it's quite, you can clearly see from the left to the right-hand side, from high-income countries to low-income countries, the number of blood pressure lowering medication classes available. And clearly, it's quite clear that in low-income regions, you can see there's only 13% of them have 4 or more drug classes available, but at least most of them have 1 or more. Whereas when you look at high-income countries, there's availability of all these drug classes in 94% and up. So that's clearly a challenge, the number of classes available, but perhaps more important is affordability. And this slide shows the proportion of households that could not afford blood pressure lowering medicines and combination therapy, then including also, for example, metformin, statins. And there you can see, again, low middle income countries, low income countries, up to 80% not being able to afford metformin and statin plus blood pressure lowering drugs. So it's often in these instances, as we know, it's not only based on drugs being supplied by the government or subsidized or having health care for all at low cost, but it's also out-of-pocket expenses and the differences in pricing in these drugs in different regions of the world. And I think, again, going back to infectious diseases, there's a lot we can learn from the HIV epidemic. And for example, and just showing this as an example, this pharma company have launched their access program to provide antiretroviral drugs at no profit to 68 developing countries. So it's often the case that there needs to be, meet of demand by also big pharma coming to the table. This was in 2003. And you can see here in the purple line is the drug costs from antiretroviral therapy going down from the year 2007 to 2018 from $12 to $3.50. But also, the green line is the global HIV funding. As we know, there's been massive contributions in improving access to antiretroviral drugs. It's an urgent medication that is needed, which is, of course, the opposite that we often have for chronic diseases where it's not as urgent. And there you can see at least the global HIV funding, the drop in prices from pharma company resulted in the red line going up, meaning a huge turnaround in access to antiretroviral treatment and a massive reduction in deaths in those regions. So the World Health Organization has been for many years trying to improve this model of fair pricing, looking at, for example, the challenge, the issue is that there's the extremes. Prices are so high that they are unaffordable, especially the new drugs, even in high-income countries, or on the other hand, prices are so low that they drive the high-quality manufacturers out of the market. That means in the end there's drug shortages because of it's not profitable for them. So it's have to meet in the middle somewhere to make sure that high-quality, affordable drugs are still produced, but in large volumes and accessible to those in low-income regions. And there's been, it's again a will, I think, mostly from big pharma to see how they can play a role. Here is a report last year from the Harvard Business School showing that there is a model. They can save millions of lives. There has been good examples of how this is possible. What is the hold-up? So there should be more conversations in terms of how this could be done and implemented and translated. And then lastly, I'll focus on development and delivery of these medicines. So the World Health Organization, you may be familiar with the ARCH program, have done a lot of work with different models and modules on, for example, the third one there on the top, access to essential medicines, trying to make sure that people can access it. They have very clear specific steps there, but obviously each country is very different. And again, lessons from HIV is one way that they've been able to really make a difference is by implementing single pill combination therapy, 1 pill a day. And you can see here there's lots and lots of different single pill combinations available for HIV. Many of them have 4 different components in 1 pill, or 2 or 3. So there's a variety of different low-cost antiretroviral drugs available. Another innovation, I would say, that we see more and more is the use of vending machines to ensure access to prescription medications. Here is an example of one for contraceptive drug use. On the right hand is one in Singapore, what they call a pharma box. That is more for a variety of different medications. I know HIV drugs are also delivered through vending machines in Africa. So it's ways to overcome the issue of healthcare workers that's simply not always available to meet the demand. And in the case of HIV, the success of the antiretroviral program has really been due to nurse prescribing, which really tripled the number of people receiving antiretroviral treatment over the past decade. So we are far off from having nurses prescribe medicines for cardiac, metabolic, kidney disease, and how to get there is really, I think, a challenge, and trying to swift our minds in terms of how we're thinking about those issues. In terms of single pill combinations, there's been many reports also in the space of high blood pressure, how effective they are in terms of improving adherence, improving persistence of using drugs over long periods of time, and improving blood pressure control, because it's a simpler treatment strategy, just one pill often instead of 3 or 4. So one of the key steps to making these changes in terms of accessibility is to get medications on the World Health Organization essential medicines list. So single pill combinations for hypertension has been added to the list, and in 2019, which have been a major step forward. And last year, a big step forward was again another addition to the WHO essential medicines list was for polypills. And that is, for example, including aspirin, statin, and a blood pressure lowering drug. And there's various ones with 5 different components, beta blocker, thiazide. So these really is a big win, because there's more and more evidence to show, again, you can reach large volumes of the population with single pill combinations that address several aspects of cardiovascular disease, not only blood pressure, but also related components in terms of statins and aspirin. And it's in different drug doses as well. This has been welcomed widely. This is just an example from the World Heart Federation, which welcomed this decision by the WHO. Others have worked for many years. For example, the HOPE-3 study showing the benefits of using a polypill to improve cardiovascular outcomes. The problem is that already in 2003, the landmark papers in the British Medical Journal already showed that this sort of strategy could reduce cardiovascular disease by more than 80%. Now we have finally, 20 years later, a polypill approved by the World Health Organization. But this is the first step, how to really implement and translate it, getting the medications developed by pharmaceutical industry, having them available, having them stable, and having them delivered is a long-term process. And unfortunately, it's taken quite long to just get to this step. Already in 2003, it was said that such a polypill strategy could prevent heart attacks and stroke if taken by everyone aged 55 and older, and everyone with existing cardiovascular disease. And we know there's obviously challenges to get that to everyone. But nevertheless, this model has been suggested to be really safe in terms of also disease prevention. And then we have newer medicines. I mean, we've just had a previous speaker also referring to SGLT2 inhibitors and GLP-1 receptor antagonists. So SGLT2 inhibitors are also listed in the essential medicines list by the WHO. It's really an important addition. And often the WHO will take also into account safety, efficacy, of course, but also safety and affordability. And a very interesting paper that analyzed SGLT2 inhibitors, but also GLP-1 receptor antagonists in terms of their cost effectiveness and their price target analysis, so that they are in fact affordable in lower middle income countries, have indicated, for example, for SGLT2 inhibitors to be actually implemented would require a relatively low 17% cost reduction, and therefore having them conclude that they hold particular promise to be implemented. On the other hand, they have looked at GLP-1 receptor antagonists and said it requires a 98% reduction in cost in order to be implemented. But this paper was then followed by a letter to the WHO from different authors, is mostly in the US, who indicated that that analysis was flawed, and there are other GLP-1s that are much lower in cost, and therefore it would actually be implementable in low and middle income countries. So they've had a different analysis of the cost, which is actually quite low for different types of GLP-1 receptor antagonists in high and low income countries, as you can see. So nevertheless, the WHO did not approve them yet for use, which is, obviously a very first important step to get them accessible in countries. But mostly due to more data required to ensure safety. So I'll stop here. I just want to summarize what I've tried to indicate, just touching on few key topics in this space, is that we have effective medicines. Fantastic clinical trials have been done already to show effectiveness. Would be better to have local data, but we know there has been demonstrable evidence that they are also effective in this region. It's about how to make them widely available and affordable. People living with low-income countries carry the greatest burden of NCDs by far. We can learn a lot from HIV and other infectious diseases, partnering with big pharma, partnering with governments, NGOs, to make sure that it's a success in LMICs, wide availability of single pill combinations, getting nurse prescribing, community health workers involved. Other innovations such as vending machines have been proven to be quite effective. And then I think polypills is now finally on the horizon to be implemented. We'll have to find models to actually make sure that they are produced and are actually implemented in countries where they are needed, and all hands need to be on deck in order to get that implemented. And then lastly, inclusion of new drugs, such as SGLT2 inhibitors and GLP-1, getting them onto the essential medicines list is the first step, then getting them onto the country essential medicines list is the second step. But government buy-in will be essential to get that done. We know they are hugely beneficial, taken the world by storm in effect. But another thing to consider in terms of giving access locally is to see whether local manufacturing within a country could be a possibility. Will improve the economy. That is something that's often reviewed carefully, and then make sure that they are available locally as well and available. Thank you very much.
So we're going to take some questions and panel discussion now. Quite thought-provoking presentations from all of our speakers. And we have prepared some questions in advance, panel, so we're not putting you on the spot. But we thought we would start with the question for the panel. We've already heard about the big problems around what we need to solve in the Asia-Pacific. But how do we really take a focused approach? And so if I want to ask each of you we did this in a previous session on women's and girls' health. What would be the one key priority or solution that you would champion for the issues that we've just heard about? So I'll ask with the Honourable Minister Lalabalu.
Speaking to it, it's on.
I heard you. Thank you. For us in Fiji, to address this issue, it's all about sustainability, and it has to go back to we have to put more emphasis on the primary healthcare setting and the prevention side of it. Looking as it is in our setting, in the Pacific setting, with our purchasing power for medications, as it is, in the long run, prevention is still better than cure. So as we put more emphasis on tertiary level of care, likewise, it should be the same or even more in terms of the prevention part of it.
Right, thank you.
So I would say for Malaysia, for example, as one of the middle-income countries, I feel that the priority should be we need to make the electronic medical record system to be up. And this would have supported the subsequent data for a strong surveillance system. When we have the data, we'll be able to generate results to inform practice and policy.
Maybe two. Data's key, I think. So we need access to data systems. They're everywhere. We need good solutions which are locally going to work that enable for us to do that. Implementation's a local game. You can evaluate something anywhere, but we need a local solution. So we need an infrastructure that allows us to do that. And I think I think particularly in countries where there has not been an investment in a clinical research infrastructure, if for no other reason than to work out how to implement evidence-based interventions, I think is something that can be done in every country.
I think it's important to think about countries next to each other. You often see some that are really successful with implementing things and one next to it not so successful. So what are the differences there? I think in many instances is a strong leadership within government to get their buy-in with a specific challenge and getting champions there. Obviously, it's not one person, it's a whole partnership with different stakeholders, including the community. But I think getting a champion in government is really important to ensure there's implementation of the best evidence. I fully agree with previous comments. I don't want to repeat the importance of data and local setup, but I would think strong government leadership is key.
I'm hijacking the panel session. Look, I've been sitting here and thinking a lot about education of our patients and stakeholders. And I know in the previous session there was a discussion about implementing cervical cancer vaccinations and that patients in certain regions weren't very motivated because they didn't understand why they should do something when they had no symptom. And I know as a cardiologist, I see patients with diabetic chronic kidney disease, and they're very worried about their kidneys, and they're very worried about their sugars. And very few of them know that 90% of them will die of cardiovascular disease, and it's only 10% that'll live long enough to see end-stage kidney disease. And when I have that discussion, all of a sudden they're quite interested in understanding how to reduce their cardiovascular risk. So I suppose I'm wondering, how important is patient education in your regions, and how are you going about it? Maybe Dr. Lim to start with.
I would say in Malaysia, we're actually facing a suboptimal level of health literacy, which is about 20. Maybe perhaps with the latest population-based survey will be released next month, which is up to about 30%. So we do have multi-level educational awareness campaigns, but it takes time. Just for example, the Less Sugar campaign. You may realize that at the community level, they don't feel the urgency of reducing the sugar intake. But if you tweak the message, you tell them, if you manage to reduce sugar, you prevent your leg being amputated, then they will get scared. So it's a matter of whether people who are implementing the programs or policy or practice were able to speak the language of that person. That will make things faster. But again, school educations, we are revamping the school education, part of the National Action Plan, trying to educate them on diabetes, obesity, all these NCDs. Even we do have community projects trying to enhance screening. But one thing that we face is a lack of follow-up action post-screening. We don't have the sufficient capacity within the publicly funded system to call back all of them who either have pre-diabetes or overweight obesity, but without significant comorbidities, to be placed under the radar. The surveillance system is not strong enough.
Yeah, I mean, a couple of thoughts. One, we've got to move the conversation away from knowing your numbers to owning your numbers. So I think just as much as the education strategy is vital, it's how we tackle misinformation. And I know that's a session in this meeting. My particular area of interest is in cholesterol and the battle that we have fought with the cholesterol skeptics and the statin skeptics. And every time, unfortunately, the popular media run an article trashing statins, you see prescription rates go down. If we've learned nothing through the last few years, we've got a community that has become a little bit sceptical of scientists and experts, and we've got to find ways to be able to counter the misinformation just as much as to tell the educational stories that we've been hearing.
Yeah, if I can chip in there, I fully agree. I think we've seen in many instances the importance of patient advocacy groups to lead these sort of information sessions if they are, well informed. Again, for conditions such as dyslipidemia, there's no symptoms in many instances. So that's again where for high blood pressure or dyslipidemia, many NCDs, that's a problem. So health literacy is really key. But even in some of these conversations that we've had with patients is that sometimes you need to have a much better understanding on their perspectives, for example, not fearful so much of stroke or heart attacks, but more fearful of having dementia later on, So how do you also frame those messages in increasing health literacy? Even in a high-income country like Australia, we see very poor health literacy in the general community for many NCDs. So I think this is a key challenge. That is a really good question. I don't have a key answer there, but I think this is very important in this conversation.
Yes, I think education and awareness is an integral part of combating NCDs and CKDs. In Fiji, we go further as to involve other stakeholders within not only, we see it as a Ministry of Health-led approach, but we also tend to rope in all the other stakeholders such as religious organizations, traditional leaders, and other relevant stakeholders to pass on the message. And that way, sometimes they're much more receptive when they send the message over.
Great. Thank you so much. And on that note, I wanted to thank our speakers and our panel for their thoughtful comments and thought-provoking numbers. I think it's fair to say cardiovascular disease, kidney disease, and metabolic and diabetes, obesity conditions are highly prevalent at pandemic proportions, if I may use that word, although that scares us. And we have a call to action in our region to do better. The numbers are very sobering. The indicators are there. We have them about how to do better. We need to strive to do better. That is a multi-sectorial approach that we need. We need to take on board the local solutions and share our learnings. And I'm hoping that we can work together on some of these great challenges. And next time we meet, wherever we meet in our region, the numbers are better. So thank you all for your participation. Thank you all for your attention. I look forward to seeing you at the reception that follows this session. Thank you so much.